So I'm delighted to introduce the members of this panel. I'm going to do it in order of how I can see them. I doubt that there is anybody here who does not know Molly Osborne, who is a critical care physician at the VA, as well as being the head of the Integrated Ethics Service there. Prasanna Krishnasamy, who is the medical director for ethics at Legacy, as well as being primary care, right? Jaime Fair is a critical care doc at Peace Health in Eugene. And finally, Laurie Mavity, our hometown favorite, who is a palliative care doc at St. Charles. And I'm going to let them take it away, and I will help with questions afterwards.
So thank you, Laurie. I have to tell you that in all honesty, last September when the Oregon Health Authority came out with its guidelines, I wrote and said to the people setting this up that I was hoping there could be a symposium that looked at the guidelines and tried to figure out what to do about the next pandemic. Well, I'm here to reassure you, after hearing all the kinds of things you heard this morning, you don't have to worry about that today. So that's the bottom line. So I'm going to talk about avian flu to the OHA, Oregon Health Authority Crisis Care Guidelines, prepare us for the next pandemic. We think the answer is actually not really. But I will introduce you to Nirmala, who's here, Nirmala, who is from the Oregon Health Authority, and I've been talking to her all morning about what we can do to make a difference. So there are no disclosures in terms of the four of us. We came here just because we love you all. Did you hear what Laurie said? It's mutual. Okay, so our objectives are listed here. 4 objectives, 4 speakers. I think you can do the math. So I'm going to talk about the ethical concepts in clinical ethics and public health. So I have to ask, I know it's after lunch, so you're all like sleeping, but because it's about public health, that is community, and clinical ethics, more individual, how many of you would say you have a public health fundamental priority in terms of your interests? So it's a very big number. I caught 3. How many are interested in clinical ethics in some way, whether it's hospice, direct patient care? So the majority, and is there anyone I've missed? And those that do both. So that's the part that I will talk about. And then Prasanna Krishnasamy will talk about a framework of the current versus the ideal versus the future states of bioethical responses. Before you memorize that, what it really means is to walk you through the current guidelines and what some of the issues are around the guidelines. And then we will hear about enumerating major challenges in healthcare resource allocation. And let me point out that you've heard all this morning about big issues across the nation, if not the globe. We're going to talk about Oregon. So we're actually going to talk about how this all fits in with what's going on in the state of Oregon. And then lastly, not least of course, as you know from this morning, address sources of moral injury and ethical tension to support healthcare workers, patients, and communities. Now, we're not going to have the answer. Remember, you already heard this morning that it's really hard to fix these things. So here's the challenge to all of you who are actually really concerned about this. If you can come up with ways that we can actually help our rural communities understand science better, you would make my day. There are many other things that we could try and do, but that's one of my biggest concerns, as I mentioned this morning. And certainly, if there's anything we can do as healthcare educators to listen, I know enough to know that I have to listen first, and maybe listen all the time. I'm all ears. So if you have ideas about it, let me know. And as I mentioned, I've been talking to people at the Oregon Health Authority to see what I can do personally, because that's what keeps me up at night. What are the key points that I'm going to tell you about in like 8 minutes, I hope? There could be another pandemic. You can see how well I can spell. But there could be another pandemic, but it probably won't be avian flu, and I'll tell you why. I wanted to talk about it because I was worried. I'm not so worried now. Now, there is a big difference between clinical ethics and public health. The reason I'm going to spend time on that is we need to know our public health colleagues much better if we're going to possibly find a way to effectively communicate when the next whatever comes. And I'll tell you a little about how we're trained, how we interact with each other, and I can tell you if you've ever talked to anybody in the community the way I do, they think I'm a public health person, which I'm not. In other words, people don't understand the difference in the communities. Then I'll talk about the necessity for public health and clinical ethics to collaborate effectively. So now you know what I'm going to say. So now you can relax for 5 minutes. So why discuss pandemics now. I feel pretty strongly about this because I did study mRNA when I was in graduate school, which I know was another lifetime ago. The infections, mostly in the 20th century, are all RNA viruses. You can argue a little about HIV having a retrovirus picture, but they're basically RNA viruses. So what that means is we don't have antibiotics for them. So what do we need? Well, better health care, I would say. And I won't point out how it's done, but I'm certainly a vaccine believer, and the mRNA platforms, of course, are changing not only how we see treating infections with vaccines, but actually it turns out the mRNA is very useful for pancreatic cancer and a lot of other things. It's a really hot area. So I know you're going to come at 2 o'clock and talk to me about it. But this is a list of H1N1, HIV, AIDS, SARS, MERS, Ebola, measles, COVID are pandemics. Avian flu is not. Does anyone know why it's not? Trick question. No. Okay, Tina, go. No human-to-human transmission. And that's, until that happens, it is not a pandemic because it has to be able to infect one person and have one person infect a large number, at least more than another. So let me very quickly go through the avian flu slides. I'll make sure they are shared with all of you if you want the details, but you've already heard the answer. It is very pathogenic. It did emerge in 1997. It is now across the globe. It's in migratory birds. It has infected every animals in every continent, and there's a particular kind, the highly pathogenic avian influenza, the HPAI, the H5N1, that has been most concerning here in this country. It actually occurred, probably started to emerge in 2020, before 2021, and has resulted in fatal infections. But the big issue is actually not me, it's the cattle, and it's the poultry, and it's the wild birds, and now the cats. Don't give any cats any live food, cook all your eggs. It's now widespread, but I was told, and this is very important to pass this on, no dairy cattle have been infected here in Oregon. So I'll show you some pictures of that, but it's not yet a problem here. Poultry, yes. Cattle, no. And the way it happens is the wild birds have, of course, migrated and now infect our poultry, our cows. The cats are now infected. This is actually a big problem in terms of it being highly fatal in cats, just FYI. But like I said, there is some human infection, but no human-to-human transmission. There are now variants across many herds in the United States, not Oregon. And so this is going to, I think, have a big effect on how we deal with our groceries in the next few years. There are variants that are happening fairly quickly. This is an example of the actual viral particle and making the point that it's affected dairy herds not only in Texas but also in Nevada, and that there are new variants that are occurring even within people when people have come down with the infection. How are you going to spot it? Well, it kind of looks like the flu. Major importance is that there are receptors in the eye for that particular virus, so they're more likely to present with conjunctivitis. So for those of you that actually do primary care, think about it in somebody who works on a farm, works with cattle, comes in with flu-like symptoms, has conjunctivitis. They actually are very interested in getting data on this, so do look for it. And other than that, it's very much like the flu in terms of the symptoms, how to prevent it, and how to avoid it. I'll just make one other point. It was thought that the mortality was going to be very high because in Hong Kong they had reported mortality of 47%. Now we'll do 1 minute of epidemiology teaching. If there's a 47% mortality and 5 people have come into the hospital very sick and half have died, you get your 50% mortality, right? But what if all the people infected is actually 1,000? Then the mortality rate is under 1%. You don't have to do all the math in your head, but my point is the initial concerns about mortality probably had to do with the few people who presented who were very sick. And it looks like the mortality in humans is much, much lower, probably closer to the 1% for the people that really have been infected through poultry contact or cattle contact, which is why the current public health risk is low. The CDC is watching the situation. In Oregon, they're watching it very carefully. Like I said, no cattle yet. And I think we're doing well. The key treatment is not exactly clear besides vaccines, which I can't mention enough. But oseltamivir is probably adequate, although the data aren't very strong at this time. So what can we do in terms of clinical ethics and public health ethics partnering? First of all, I think as much as we can, we need to get more funding for public health. I think you already know that, but I'm just going to spend a minute on the difference in training. Think about healthcare ethics consultations as dealing with cases. I'm an ethics consultant, so I'm going to deal with cases. I have staff support. Thank you, Julia, who's in the audience. Everybody knows if you ever have an assistant who does all the work, I'm just saying. Policy, staff support, community engagement, education are all part of it. But public health is actually trained differently, siloed differently in terms of funding, and works to look at the community, not the individual, in terms of health promotion, harm reduction, surveillance, communicable disease prevention, communication, health equity, local and regional partnerships, home visiting programs, emergency preparedness, environmental health, and health promotion. Or if you will, what I want you to do with this is think, okay, if individual autonomy is about the individual and common good is about social justice, think for a minute, okay, some of you are already public health, but for those who are not, here's the dilemma. Pretend for a minute you are a public health person in Oregon, and the issue is, are you going to make sure that with COVID, the rate of spread in terms of significant morbidity and mortality is low? You don't want to overwhelm the healthcare system. People are already dying with inadequate healthcare support, but the individual may not have adequate schooling for 3 years. So as a public health person, how do you balance the community and the individual? Like I said, there's no quick answer here, but I think that's what we have to wrestle with the next pandemic. So the basic concepts for clinical ethics are individual, autonomy, treatment. We're all familiar with that. But look at the red at the bottom. Authority is based more on prestige of the medical profession than the law. And what's the problem in 2025? The prestige of medical profession, under a lot of dispute. 40% of people in Oregon, if I can steal your thunder, are not vaccinated. That's a concern. And you're going to hear more about that from the other speakers. Public health is focused on the community, and how well do we have trust in the community? I'm passionate about trying to educate, which means listen to the community to try and find out how we can try and address this so that stakeholders have a fair hearing. And my last slide, we need social cohesion, collaboration, and community leadership. I don't think that's a surprise to anybody in the room. But the question is, how do we do it? And when you have your answers, please come see me. How can medicine align with different beliefs about treatment, prevention, and access? And thank you very much.
Good afternoon, everyone. I'm Prasanna Krishnasamy. I'm the Medical Director of Clinical Ethics at Legacy Health. And I was part of the Crisis Care Community Ethics Task Force in 2020 as part of the Crisis Care Guidelines and the Oregon Resource Allocation and Advisory Committee. So I'm going to share my experience and learnings from that. So I'm going to be speaking to you guys about the current status of the Oregon Crisis Care Guidelines and then compare it with Washington State Guidelines. I work for Legacy Health. We have a hospital across the river in the state of Washington, so we had to deal with both guidelines. And what would be an ideal state for crisis care guidelines? And then what can we do in the future to get there? By the way, so this Six Sigma is actually a lean methodology of thinking about process improvement. So the current versus ideal versus future, that comes from that. Okay, so this is the definition of crisis standards of care from the Institute of Medicine. It's a substantial change in usual healthcare operations and the level of care it is possible to deliver, which is made necessary by a disaster. This change in the level of care delivered is formally declared by a state government. The formal declaration that crisis standards of care are in operation enables specific legal regulatory powers and protections for healthcare providers. So I'm going to point out two key aspects here, that it should be officially declared by the state government, and it provides protections for healthcare providers. And I'll circle back to this when we talk about the Oregon Crisis Care Guidelines, where these two key aspects are missing. And this is a slide on the continuum on standards of care. So typically we talk about conventional, where we provide usual care, contingency, where we have implemented measures to provide functionally equivalent care, and then crisis, where we are doing triage and rationing of care. And typically we think about three things when we think about triage and rationing: space, staff, and supplies. As you know, there's a lot of attention about supplies, right? It was all about the ventilator in spring of 2020. But what really came into play with Delta wave and the Omicron wave was staffing shortage, and nobody was prepared for that. This is a timeline for the development of the Oregon Crisis Care Guidelines. So in June 2018, after many years, 10 years or some years of work, a lot of collaboration across the state, the Oregon Health Authority published the Oregon Crisis Care Guidance. And then in spring of 2020, we had the task force established with the leadership of the Tri-County Public Health, bringing us together. That's when we are looking at the literature. Everything dates back to 2018 or before. How do we make it practical? That was the challenge in front of us, more specific for COVID. And then just about 1 to 2 months later, there's a lot of equity and disability rights concerns on the existing guidelines. How the existing guidelines, if they're implemented, would worsen inequities. And so in late 2020, OHA scraped the previous guidance, so no guidance. And December 2020, we have 4 principles in promoting health equity. So 4 abstract principles and a lot of what not to do. And then about a year later, just before the Omicron wave, we had an interim crisis care triage tool. And then in 2023 and 2024 is when the Oregon Resource Allocation Advisory Committee was established. We worked through the guidelines, and that work ended last June, and a draft has been published in December of 2024, and it's open for public comment. So I want to point out 2018, September 2020, is when the 2018 guidance was withdrawn. And then we went into Delta COVID with just 4 principles and a lot of what not to do to not get into trouble. And then only because we kept on, asking, just before the Omicron wave, the interim crisis care triage tool was released in Jan 2020. Omicron crisis was February 1st week. So I'm going to go through some of the key aspects of the current Oregon Crisis Care Guidance. So the goals of the guidance are twofold: saving lives and to not worsen health equities. I've pointed out some of the key things here, but in Oregon, they leave it to the hospitals. So hospitals may activate crisis standards of care, not the state. Hospitals should take all possible steps to avoid a crisis. Hospitals should coordinate with various stakeholders. And there is an Oregon administrative rule that requires hospitals to notify OHA and the public if they go into crisis standards of care. And hospitals may use their own crisis care triage tool as long as they align with the 4 OHA's principles of non-discrimination, health equity, patient-led decision-making, transparent and effective communication. And then these are another couple of important aspects about the Oregon Crisis Care Guidance. So they emphasize individualized assessments. The focus is on the prognosis for hospital survival using the best objective medical evidence. Do not use any clinically or ethically irrelevant factors in triage considerations, such as race, ethnicity, etc. And reasonable accommodation should be made for persons with disabilities. And then early on, make sure that you're assessing patient preferences, goals of care, particularly with regards to hospitalization and intensive care. This is the recommended crisis standards of care triage team under the Oregon guidance. As you can see, it is very extensive. It's more aspirational than practical. So it requires 2 or 3 senior clinicians with at least 1 physician and 1 nurse, a medical ethicist, expert in DEI, a disability rights representative, a non-clinical community representative, and an administrative assistant. And all the team members should have training in bias, trauma-informed care, and anti-discrimination. Now, Legacy Health is a large health system. I have trouble locating 6 people like this in the middle of a crisis. This is a snapshot of the crisis care triage algorithm for Oregon. I don't want to go into the details, but the focus is on prognosis for hospital survival, which is survival to 30 days, hospital discharge. And then one of the unique things about Oregon is that built-in pause and assess for bias and clinical consistency. Whatever clinical factors or judgment you use, stop and think whether it makes sense or not. And then we categorize people into 4 categories based on the probability of survival. It's easy, like more than 90% survival, and then less than 10% survival, everybody in the middle. That's where clinicians get it right when they say I have more than 90% confidence or less than 10% confidence. The rest is just like a coin toss. I think we are just fooling ourselves by making prognostic calls. And then if there are less resources than the number of people in each group, you end up in a tiebreaker. And Oregon is unique that it has an equitable chances tiebreaker. So this is where they bring in the equity consideration. And so they are using a disadvantage index. An example is the area deprivation index. So the more deprived the area of social services, then you have a higher score. So a person with a higher score will get more weight in the weighted lottery. So they are more likely to win in the tiebreaker. So this is unique about Oregon. It was very thoughtful. The only downside is it is done on the back end. Not everybody is reaching the door of the hospital equitably. And so this is done as a second step, not as the first step. So now I'm going to talk to you about the Washington Crisis Standards of Care. They released this in October of 2021. They had issues with equity and disability rights concerns too, but within a year they were able to put together crisis care guidelines. So some of the key aspects, the document starts with a statewide commitment to work together and share information and resources. Crisis standards of care will be declared by the state at the state level. No hospital or region will go into crisis standards of care alone. This is very different. We all know during Delta and Omicron, some of the hospitals in Southern Oregon, Eastern Oregon triaged. They were in crisis. Nobody declared it. Because if you declare it, you get it in the media. There's a lot of issues with that. There was an analogy we talked about. There's only so much you can dilute a soup, and then you can't tell the difference between water and soup. And that's what happened with nurse staffing, right? They kept on increasing the number of patients. And these are the ethical principles guiding the Washington Crisis Standards of Care. This is just an overview of the operational steps. They were much more detailed in helping hospitals implement crisis standards of care. So there's the patient data entry piece, the triage team piece, and then the allocation of scarce resource and the tiebreaker mechanism, and then a separate mechanism for communicating these decisions back to the primary team, patients, and families. And this is the crisis care triage team recommended by Washington. It's much more simple and practical. 2 or 3 clinicians, senior clinicians with at least 1 physician, a medical ethicist, and an administrative assistant. But here is the key piece. So the triage team need not be at the hospital level. Hospitals can collaborate and create regional teams. So they explicitly allowed hospitals to work with each other and help each other during a crisis. And this is the algorithm. It looks very similar to Oregon because we developed Oregon based on this model. More than 90% survival and less than 10% survival on the 2 ends and the rest in the middle, primarily focusing on the likelihood to survive to discharge with the resource if they are given that. Their tiebreaker process had 4 steps. And level 1 is the resource will remain with the patient who already has the resource unless they are clinically declining. Pregnant patients will be given priority, saving lives, right? There's 2 lives there. The third is where they integrated the disadvantage index, and they used social vulnerability index specific with Washington local data. So again here, the equity consideration is coming in not at the front end, somewhere buried towards the end. And then the last step would be randomization, not weighted lottery, not equity-based, but just simple randomization. So I'm going to walk you through the strengths and opportunities for both Oregon and Washington. In Oregon, I think the strengths are the focus on equity, non-discrimination, and communication, the emphasis on individualized assessments, don't use tools like SOFA, which has a lot of bias and discrimination built in, and I think the equitable chances tiebreaker is unique to Oregon. In Washington, I think the main strength is the statewide commitment to work together, and that crisis will be declared at the state level. No hospital or region will go alone. And when I attended both state meetings where we are discussing the details, operations, there was a lot of sense of cohesion, collaboration, and community in those meetings. I did not have the same feeling when I was working with the Oregon Resource Allocation Advisory Committee. As for opportunities, I think Oregon should seriously consider about state-level declaration of crisis standards and coordination and support for the health systems and hospitals, and consider explicitly allowing hospitals and regions to support each other. And what happened was there was a concern about collusion and antitrust with hospitals being able to work together. And because of that, there was a limited collaboration going into Omicron and Delta. Simulation exercises, we learned a lot about actually using the tool on real patients in the ICUs at Legacy. That's when we realized, oh, some of these things on paper look great, but they don't work. And it's important to have liability protections for hospitals and healthcare providers. As for opportunities for Washington, I think they should consider integrating equity and non-discrimination considerations. I don't know if they did simulation exercises, as I was not part of the development of their work. They don't explicitly speak about liability protections, like I think a couple of states, like state of Maryland and another state where there is a governor's order for 90 days, or there is another state where there's a legislative protection. So when they go into crisis standards, they are protected. But my take is, since the crisis is declared by the state, it probably is not an issue in the state of Washington. So what would be an ideal state for crisis standards of care in Oregon? I think we should aim for crisis guidelines that is widely accepted. I don't think we can come up with anything universally accepted given how diverse and polarized we are right now. I think state level declaration, coordination, and support is definitely required. Explicitly allowing hospitals to work with each other, and a tool that is informed and modified by simulation exercises and real-time data. One of the things we realized is we kept on thinking about the tool for COVID, but tomorrow it could be an earthquake. Day after tomorrow could be a tsunami, right? The same tool may not work in the same way, and we got to be more agile when we are using a triage tool. And then liability protections for hospitals and healthcare providers. So what can we do now to move towards that ideal state? The last time we met as the Oregon Resource Allocation Advisory Committee was last June. Since then, we haven't had any meetings, no further work, at least being done in the public arena. So I think we need to continue to work on this, engaging the various stakeholders. I think we made progress, just not enough if we are to face a crisis tomorrow. I think we need to do simulation exercises on the existing approach and tool, and then refine the guidelines based on input and data, and then explore how we can think about state-level declaration and liability protections. Thank you. This is moving forward, moving back. This is the point.
Okay, that one does work. Hi, everybody. Okay. I have the opportunity to talk with you a little bit about crisis standards of care, and my job on this panel was to talk about what it's like outside of the western part of our state. So I'm hoping to highlight how healthcare systems in rural Oregon are geographically isolated. Of course they are, as compared to metropolitan systems. I'm going to talk about how that lack of framework for collaboration in a practical way in our current Oregon crisis standards of care really exacerbated that isolation for healthcare systems who are in rural areas. And I am going to talk a little bit about how devastating the impacts were during COVID. So this is a map of our healthcare regions as broken up by our Oregon Health Authority into our healthcare regions. And you'll notice there are a total of 7 regions. And as they're broken up, 6 of the 7 regions have a regional resource hospital. Over in Region 1, we've got OHSU, Region 2, Salem, Region 3 is Sacred Heart, Region 5, Asante. Region 6 doesn't have one. St. Charles is Region 7, and then Grand Ronde Hospital over in Region 9. And Grand Ronde Hospital is a 25-bed critical access hospital. That's their job, to help coordinate for that region. This map I put up intentionally just to talk about the density of healthcare in Oregon, and this is not a surprise to any of us. We know that most of the healthcare institutions in Oregon are on the west side of the state because that's where we're more densely populated. It totally makes sense. The concentration is in the northwest part where Portland is, Salem as our capital there. It all makes good sense. Of course we have more healthcare there. But what happens then is really truly that like geographic isolation. Not only that trip over the Cascades in the wintertime, which can be treacherous at best, but then also in southwestern Oregon that is really far from a lot of the bigger healthcare systems. And even the density of critical access hospitals, there are actually 10 critical access hospitals on the western side of the Cascade, and there are 10 critical access hospitals total on the rest of the 2/3, 3/4 of the state. As Prasanna really nicely highlighted, the current standards, crisis standards of care, allow hospital systems to choose their own crisis standard tool as long as they don't violate any laws, and the good guidance that Oregon built into that of trying to not discriminate against patients. And so just to talk a little bit about the other side of the Cascades that is further away from other health systems is felt like, well, when are we supposed to activate these crisis standards of care? And God forbid be put in the news for doing it. What triage tools should we use? How to assemble that triage team? I totally borrowed one of Prasanna's slides because I loved it so much. But let's look at this crisis care standards triage team. In a rural critical access hospital, those 2 to 3 senior clinicians are probably taking care of patients, much less trying to be part of a triage team. And they probably have never, maybe they have had to triage if there was a bad motor vehicle accident nearby their hospital, but probably most of us haven't had a lot of experience with that. There are no specifically designated medical ethicists on the east side of the Cascades. Experts in diversity, equity, and inclusion are incredibly rare to find in a critical access hospital, much less a disability rights representative. And finding enough people who have training in bias and trauma-informed care and anti-discrimination in a small hospital with 25 beds is virtually impossible. And so back to this, what this really left hospitals and health systems east of the Cascades feeling like was, oh my gosh, we're not gonna take care of the right people, and we're not gonna do it right, and we're gonna harm people, and we're gonna harm our community, and we're putting ourselves at risk for doing it. I want to talk a little bit about some of the other impacts that happen during crisis standards of care. And for non-academic community hospitals, a lot of those hospitals survive on their bottom line from elective surgeries. During COVID, we had to cancel all of the elective surgeries and even the like semi-urgent surgeries because there was no bed for a patient to go to post-op. And so because those surgeries were canceled, not only were we already constrained with trying to hire enough staff to actually take care of patients, but then we were losing money by the month by not being able to do those elective hip repairs, total knee replacements, the things that actually, unfortunately, currently help fund healthcare in this country. Cancer care, oh good God, that went so incredibly poorly. Anybody else I know everybody dealt with the platinum-based chemotherapy shortage, trying to figure out who deserved to get the carboplatin and who didn't. That was horrible, much less patients not being able to get the resection of their early diagnosed cancer. We're still dealing with catching up with colonoscopies in Central Oregon from COVID, much less other parts of the state east of us. And all those delays in screening and preventive care. I know we all know this, but when you diagnose a cancer later, it's worse and it's more expensive to take care of that patient, much less the distress on them and their families. We're still catching up with sleep studies. And my goodness, the cardiovascular implications of untreated obstructive sleep apnea while we're trying to catch up with these is just devastating for our communities. I couldn't help because I'm a palliative care doc, so I had to talk a little bit about palliative care as we talk about all of these important ethical issues. But I really loved this in the current crisis standards of care, the call out that we really should be trying to make sure that we understand what a patient's goals of care are, what their treatment preferences are. Would they want to be on the ventilator? Would they not? Would they want to go to the ICU? Would they not? Do they want to be coded? Do they not? And knowing whether these are something someone wants is really important as part of the triage, to be honest, to figure out if they really want that or not. In a rural setting where there are maybe no trained palliative care specialists, and these could be really high-level goals of care conversations, like, can we pull this off, especially without partnerships? And so this is my last slide, and I wanted to talk about some of the impact about the lack of a true, laid out framework and structure for collaboration between regions in our state, and the impact that had for more rural healthcare systems. And so it was really hard to figure out how to take care of expectant patients. And as we talked about this while we were working on this together, Molly was like, yeah, expectant. I'm like, yeah, not the good expectant. In crisis triage, expectant is a patient who's in that percentage that Prasanna talked about that's not probably going to survive. And the best we can do is provide good comfort, focused care for them. Well, how do we do that when we don't have any hospital beds? There were morphine shortages. There are still morphine shortages. There were Ativan shortages. There were shortages in all the medicines to do the right, good comfort care, much less beds. And we had patients who died in corridors. That was shameful, to be honest. And that's not the kind of sacred, compassionate care we want to provide to anyone who's in their last minutes to hours of life. What happened because of the regional lack of coordination, especially around the very scarce hospital bed situation, is patients would be transferred from all over the state to very far spots from their home. We had patients who were transferred to St. Charles from Gold Beach, Coos Bay all the time. I'm not sure how we got to be a pipeline for Coos Bay, but we got a lot of them. Goldendale, Washington. And patients were sent, and then we figured out, oh my gosh, we can't help them, they're gonna die. I can't tell you how hard it was to get them home. And when you couldn't get them home, then they died alone in our hospital without their family and without their support persons. And so in our future state, that coordination so that we try to do our best to care for the patients who are gonna die in a crisis has to be a top priority.
Hello, I'm Jaime Fair. I'm an ICU and intensive care physician in Eugene, Oregon. And I was one of the frontline healthcare workers through the worst of COVID, all of the surges. And I was also a co-chair with Prasanna at the very beginning of COVID in 2020, working on a triage tool, an equitable triage tool, in the event that we had to allocate resources. So the overarching theme of this conference about addressing sources of moral injury for healthcare workers, that hits pretty close to home, and then preparing for the next pandemic is also extremely important to me. So I have a lot to say. I'll try to narrow it down into 15 minutes or less. When I asked other physicians and the ICU nurses and nurses throughout the hospital that worked in the trenches during COVID, what were the most agonizing parts of the COVID surges for you? What were the sources of moral distress? They said that there was never a crisis declared. Nobody in hospital leadership, nobody at the state level said, oh, we're in crisis. It was never defined. And so on the ground, it felt like a weird gaslighting. We all felt like we were definitely in crisis, but nobody said, you are in crisis, and these are the resources that we will help you with. Of course, the healthcare worker shortage. And I think worst of all, or one of the primary sources of moral distress was that frontline healthcare workers were embroiled in a culture war that we did not anticipate. So these are the three things that I'll be talking about, and looking forward to how do we plan ahead for these. That's my focus. I'm going to just rewind a little bit to 2020, even though it's painful, just so that I can set the cultural stage for what happened in our state. In January of 2020, the very first COVID cases were diagnosed in the United States and in Oregon, and that is when the crisis care guidance was resurfaced, and we began our task force work on a triage tool. In April of 2020, the disability rights groups brought forth multiple cases in Oregon of cases of discrimination against people with disabilities. 1 month later, in May of 2020, was George Floyd's murder, and that kicked off 100 days of protest in Portland. And so there was this confluence of things. There was our work on triage, and then this focus on discrimination and the concerns about triage tools compounding discrimination, especially against people with disabilities or people from minority groups. So in September of 2020, the Oregon Health Authority withdrew the previous guidelines because of the concerns of discrimination against people with disabilities or minorities. And almost simultaneously with that, in September of 2020, was the worst wildfire season in Oregon history, where rural hospitals who were right on the fire line were embroiled in their own immediate crisis, and they were talking about evacuating hospitals. So it was a little kick in the teeth. All right, fast forward 4 years, December 2024, the draft of the crisis care guidance was released. And the good work that came out of this moment in Oregon history was that the new updated guidelines really focus on diversity and anti-discrimination. The new guidelines do a lot to mitigate discrimination in triage. And important community stakeholders were involved in developing these the crisis guidelines. When I think about the work that still needs to be done, I go back to what did the frontline healthcare workers say were the main sources of moral distress. And the crisis care guidance as it stands now actually doesn't address any of those concerns. There are really no concrete mechanisms for declaring crisis. There's an almost prohibition against coordinating at a regional or state level. And there's really no plan or no discussion about this widening cultural gap that we have in our country and in our state. The next couple of slides will just review what Prasanna and Laura talked about, so I'll kind of breeze through this. But the current crisis care guidance says that individual hospitals, individual institutions can declare crisis when resources are severely limited. What we learned from COVID was that no individual hospital was willing to raise their hand and say, we are in crisis. There was this abdication of leadership in that domain. Is it because we lacked definitions of crisis? And I think that was part of it, especially in the dimension of healthcare worker shortages. We talked a lot about who gets the last ventilator, but we didn't actually ask how long can one nurse work, and for how many shifts in a row, and for how many months in a row. How many patients can one physician see every single shift, and for how many months? As we look forward to planning for the next crisis, which is likely in the next 10 years, how do we define crisis? How do we set limits, humane limits for our healthcare workers. And then what Prasanna talked about, the Washington model of no hospital goes alone, overcoming some of the barriers for hospitals to say we are in crisis so that we can mobilize resources to support each other. We know that there's a healthcare worker shortage. The projections for healthcare worker shortages are especially grim for rural areas. Healthcare worker shortages will persist for at least the next decade. Prasanna and Laura also talked about the makeup of the triage teams that is outlined in the crisis care guidance. And as they pointed out, these people don't exist, especially in crisis. We learned this in the Delta wave of COVID. If I was participating in a triage team, that means that 20 patients wouldn't get care that day. So how do we overcome, how do we work together to offset some of the healthcare worker shortages, especially in rural areas? And one way that we can do that is have a structured way of sharing regional and state resources. That will require, statewide leadership. Okay, the cultural divide. Whew. It's called many things. It's called a culture war, culture divide, partisanship, tribalism. More often lately, what I've heard in philosophical circles is that it's becoming called an epistemic divide. Epistemic means relating to knowledge or the acquisition of knowledge. So epistemological questions are, how do we know what we know? What is true? What is the difference between opinion and fact? And how do we know what the difference is? Like, how do we know that that is opinion versus fact? The scientific method is an epistemic structure for accessing or understanding truth. So an epistemic divide is a divide of understood knowledge or understood truth. And in our state and in our country, this epistemic divide happens along many domains. It is geographical, it is urban and rural, it is political, socioeconomic, educational, religious. But for the purposes of this talk and this conference, the epistemic divide is happening along medical resources, medical education, and medical knowledge. The worldview divide, the epistemic divide, I think is one of the primary stressors for healthcare workers. I think in rural hospitals, definitely in Eugene, which was, it's outside the Portland area. But this divide is widening, and it is a predictable future stressor for our system. These are some quotes from my COVID patients. I had multiple patients who died of COVID while not believing that COVID existed. And when I got through my own existential angst and grieving process, what I came to realize is that all of these quotes represent the people from the other side of this epistemic divide. And what they were saying to me was, I don't believe you. Whatever my truth is, they didn't have access to it. They didn't have access to my understanding of medicine or my knowledge base. And it was anguishing for them and for all the healthcare workers. I'm going to go through a couple of maps to illustrate the epistemic divide. Okay, this is just a map of Oregon's population density. We have Portland in the I-5 corridor and Bend, and then the rest of Oregon rural. This is a map of Oregon hospitals, like Laura showed. The density of hospitals, of medical resources are in Portland in the I-5 corridor and in Bend, and then there's the rest of Oregon. COVID vaccination rates in 2020. So back just before the Delta surge, this is a map from the OHA. The purple areas, so Portland, the I-5 corridor, and Bend were more highly vaccinated, and then the rest of Oregon, rural Oregon, was less vaccinated. Who is getting sick from COVID and who is dying from COVID? This is an Oregon Health Authority PSA from July 2021, In the bottom there, it says 9 in 10 COVID-related deaths occurred among unvaccinated people. So 2021 COVID rates by county. The blue counties had lower than average COVID rates. The orange counties had higher than average COVID rates. That tracks with the map of the vaccinations. So disproportionately, people in rural Oregon were unvaccinated. They were getting infected with COVID, and then they were dying of COVID. And that's what we experienced in my ICU. 90% of my patients were from rural Oregon, and they were unvaccinated. I thought this was a really interesting comparison. So on the right, you can see the 2021 COVID infections, and on the left, that's the map of the 2024 presidential elections. And they are essentially identical. I'm not showing this to add gasoline to the dumpster fire of political division. I want to point out that our medical resources are concentrated in Portland and the I-5 corridor, along with liberal-leaning values, liberal-leaning politics, and it groups with people that participate in public health and people that are more willing to be vaccinated. But our patients in the Delta surge came from the rest of the state, from a different ideological background, from a different worldview, from a different epistemic structure. The crisis standards of care that were published by the Oregon Health Authority are from the point of view of clinicians, medical ethicists, left-leaning populations. And a lot of the state, a lot of Oregonians explicitly reject those priorities. A lot of Oregonians explicitly reject DEI. They explicitly reject any kind of medical credibility and explicitly reject public health strategies like vaccination. And this sets up a problem for the medical establishments because on one side of the epistemic divide are the healthcare workers and the medical establishments and the medical knowledge, and on the other side of the epistemic divide are our patients, the people that we are serving and trying to connect with. Those are the people that are predicted to be the vulnerable in the next pandemic. If we continue on our current trajectory, I think we should just brace for impact. But I think that there's a better way, and I am actually going to pull from Dr. Rushton's presentation this morning. We, at this point, we can't afford to stay siloed in our epistemic structures. It is one of our imperatives to practice perspective taking so that we can understand and connect on a human level with our patients, with the people that we serve. And she also said this morning, and I love this, that in highly unstable or highly polarized environments, we can be the small islands of coherence in a sea of chaos. So I'll end with that kind of hopeful note. And thank you for talking this morning. I actually, with this particular slide, I would like to change it to say answers, question mark, because I don't have answers.
Also,
Thank you.
If you can express the answer in 3 minutes, that'd be great. So, questions? We don't have a lot of time, but we do have a little bit. Tina, Dr. Castellares.
So I'm interested about the liability protections for hospitals and health systems. I'm wondering if they, for future, could extend in Oregon, where we need this, to protecting hospitals and health systems for working with one another, for the collaborations, because apparently all this antitrust paranoia or fear has stymied us so far.
I complete.
Testing.
Yeah, thank you, Molly. I 100% agree with that. You know, it was very funny that ethics, we all love to work with each other. So all these health systems are working together. We'll go to these meetings, and then we'll finally conclude, oh, I'm going to implement the same protocol as legacy protocol. You're going to do it as OHSU protocol, and you're going to do it as Providence protocol. But the tension it created, right, because of lack of explicit allowance for hospitals to collaborate with each other. The chief medical officers were meeting, the chief nursing officers were meeting, but everybody had to implement the standards in a silo in their own health system, which when you think about it from a justice standpoint, you know, there's like 4 or 5 major hospitals in Portland within 10, 15 mile radius. A patient in a community could be triaged differently depending on which hospital they go to within 10-mile radius. That's not justice.
One more.
And of course, you're welcome to come up during the break and talk to us, no problem.
Somebody pointed over here.
Oh, okay.
Must have been you.
I won the lottery. So one thing that I didn't hear you touch on, and one barrier to the vaccine, is our government officials were either not truthful with us, either through ignorance or manipulation, however you want to look at it. But people don't trust the information they're getting. For me, it seems like we need, as a medical community, to be open and forthright and building that trust again for the next pandemic. If not, people are not going to get vaccinated because they don't trust us. What are your thoughts on that?
I'll speak quickly and then see if others want to comment. First of all, I completely agree. I think that the question of how to build trust is something it keeps me up at night. I'm not sure of the answer because people have to trust people that they know. So if I go out to rural Oregon, I'm a short old person, and I'm from academics, they're not probably going to believe what I say, even if it's the truth. So how do I find people, the public health people in rural Oregon, who are willing to talk about, say, taking care, I talked about this with you this morning, Nirmala, talking about suicide prevention, big problem among the farmers, talking about healthy aging, dementia is a big problem that is only going to continue, in order to actually build trust and talk about other kinds of things that are more polarizing than healthy aging or dealing with suicide prevention. I think that's one way to do it. I don't have the cure, but it's certainly but I certainly welcome input.
You know, I would add that it's very important to reach out to people, understand the differences, you know, understand the different positions, and try to figure out where the common interests are. Some of the core values, you know, cross many barriers. You know, how can we use that as the space to try to bridge the gap? I'll share one example of where the medical field contributed to worsening of trust is when you think about the crisis care guidelines in early 2020. Many states, they had compliance with the HHS. They were taking into consideration quality of life considerations for triaging, right? Not on hospital survival. There were patients would be excluded because of quality of life considerations that Oregon had to fight and have specific provisions in place. Like people who live with ventilators at home will not have their ventilators removed if they come to the hospital. You shouldn't be having to say that explicitly. Those concerns were real, which actually contributed to worsening of the trust in the medical community. And since clinical ethics is mostly housed within the health systems, we lost our credibility too.
I think we're at time. Thank you very much, all four of you, for a very thought-provoking discussion. These guys, I think, anticipated that they might not have a ton of time for questions and have offered to be available at the break as well. Thank you. That was so good.